So much, Professor Rassweiler, and thank you so much for the MS webinar for having me here today. So today is a very sunny day here in LA, 6 a.m. So I'm very, very happy to be here with you and with all the esteemed colleagues. So I will talk to you about the robotic partial nephrectomies and the impact of surgical host and disease factors that may have any kind of impact on on the perioperative outcomes and on survivals. So I have nothing to disclose. So as you can see here from this chart that is coming from the surveillance epidemiology and the results of the SEER program, the kidney cancer represents the 10th most common malignancy in both males and females. And in the United States in 2022 are expected around 63,000 new cases and more than 84,000 cases in Europe. And as you can see here, the trends are going up over time due to the new imaging techniques that can find some incidentalomas. And as you can see here from the slides, that is showing that the 74.1% of the patients with kidney cancer survive at 5 years. And, when we have this kind of cancer, one of the things that we have to consider is that radical nephrectomies and partial nephrectomy represent the gold standard for the treating of this type of cancer. And though the randomized trials that has been published are showing that equivalent tumor control and superior functional outcomes, when you're looking at the RCT or CT 30904, confirmed the oncological findings, but failed in demonstrating any strong advantage in terms of renal functional recovery for partial nephrectomy. Those are the results for the randomized clinical trials. In the real world data, we know that this is totally different. So one of the things that we have to consider is that the partial nephrectomy is the recommended treatment for small renal masses, T1 tumors, so less than 7 centimeters, in solitary kidney, bilateral renal masses, and when you have a compromised preoperative renal function. And looking at these, we know that in the past 20 years, we witnessed with the important shift and swing from the open surgery to the laparoscopic surgery to the robotic surgery. And Professor Rassweiler is one of the superstars, our rock star in our field that bring really the new minimally invasive surgery techniques into this field. So, and here you can see how the trends over time change, especially in the US. So here you can see the data from the Premier Care database, a huge outpatient database that is collecting millions of patient encounter. And right now, as you can see here, the robotic partial nephrectomy or the robotic approach is the preferred approach that passed from 0.6% around 2006 to around the 66% right now in the US. The other 34% are done laparoscopically. So I would say that right now, open partial nephrectomy is something that is not even an option, especially in the developing countries. So, and the other thing that we have to consider is that how also our patients are looking for information on Google. So here you can see one of our recent publication that was looking at the trends over time of searches on Google. And as you can see here, for robotic surgery, well, there is a huge increasing trend over time with 33% more of searches on Google from patients all over the world looking for more information regarding the robotic approach. So 2004, why is important? Because in 2004 has been published the first report on robot-assisted laparoscopic partial nephrectomies, and from 2004, and they were concluding that the Da Vinci's assisted partial nephrectomy is feasible and can be safely performed using a transperitoneal or a retroperitoneal approach. So again, one of the things that we have to consider is that what happened after 2004. So when we are looking at the publication that has been published from 2004, 2018, etc., as you can see, there is a huge trend over time of new evidences regarding the robotic partial nephrectomies. So for this reason, we decided that, and of course, on the robotic partial nephrectomy, so on the outcomes after robotic partial nephrectomy and talking about survival outcomes, perioperative outcomes, etc., there are three key factors that has been taken into consideration: surgical approach, the tumor characteristics, and the patient characteristics. All these three characteristics of patient, tumor, and approach may have an impact on the outcome of interest. And so one is naturally wondering how robotic partial nephrectomy in 2022 compares with the other surgical approaches, how robotic partial nephrectomy techniques compare each other, and how tumors and patient characteristics impact on the perioperative outcomes of patients undergoing robotic partial nephrectomies. So we try to answer to these three key questions, performing a comprehensive systematic review and cumulative meta-analysis, looking at perioperative outcomes, functional outcomes, and oncological outcomes, evaluating all the possible aspects that may influence the outcomes after partial nephrectomy. And we summarize all those findings in a 4 paper that has been recently published in a European Urology Focus and Journal of Urology. So if you want to read more about the summary that I will show right now, everything is reported in those 4 publications. So we performed, of course, a systematic review looking at the, according to the PRISMA. Everything was rated according to the Oxford level criteria. We followed the AHRQ guidelines, and we registered, of course, our protocol on Prospero. We search on PubMed, Scopus, and Web of Science, and I will make it for sake of brevity. Here you can see the total number of papers that we reviewed. So we reviewed around 12,000 papers. 270 papers were included in this systematic review and meta-analysis, looking at almost 45,000 patients underwent any kind of partial nephrectomy approach with several surgical approach and techniques and 10 patients and tumor characteristics. And we try to condense everything in 856 forest plots that you can find in the supplementary material of our systematic review. But of course, as you know, for sake of brevity, it's always difficult to show 56 forest plots. So we decided to create a new composite criteria. The name is summary forest plot. And then now I'll show you just how it works. And then we can move to the results of the comprehensive review that we made. So typically, a systematic review and meta-analysis evaluate a mean of 16 papers, generating a mean of 6 forest plots. And as you can see here, our systematic review evaluated 270 papers, generating 866 forest plots. So to try to summarize everything, as you can see here, this is just an example of all the outcomes of interest that you can find in the panel A, and we summarize them in the panel B. And we call these summary forest plot, where you can see here in each line represent one of the forest plot. And if you want to find more information regarding that particular comparison, you can find all those informations in the supplementary material. So let's go and try to make it simple. And as I used to say to our students, our residents, just follow the diamonds. So let's talk about the impact of surgical factors on robotic partial nephrectomy outcomes. So we talk about the comparison of open versus robotic, laparoscopic versus robotic, transperitoneal versus retroperitoneal, and the different type of ILR technique control, such as off-clamp versus on-clamp, selective and super selective versus on-clamp, early on-clamp versus on-clamp. Let's focus on the open versus robotic. So as you can see, a number of studies that were reported were a total of 33 papers with taking into consideration data from almost 9,000 patients. On the right side of the screen, you can see the forest plot, the summary forest plot. Each line represents one of the outcome of interest. So when we are comparing open versus robotic, the open approach was superior compared to the robotic approach in terms of operative time and work ischemia time. The superiority of the robotic approach versus the open was in terms of estimated blood loss, transfusion, postoperative complications, length of hospital stay, readmissions, and 90 days. The eGFR decrease, the overall mortality and the recurrence, but no equally outcomes in terms of conversion to radical nephrectomy, intraoperative complication, even though there is no formal, so far at least, no formal definition for the intraoperative complications, which will be answered by the Icarus global surgical collaboration shortly. No differences in terms of post-surgical margins, and no differences in terms of cancer-specific mortality. So so one of the questions that we can have is, okay, we know that there is a selection bias in the majority of the cases. Bigger tumor and tumors that has an higher RENA score, of course, undergo an open surgery versus the robotic approach. So we try to perform some sensitivity analysis according to the RENA score. So selecting only those publications for which the RENA score was similar between the two cohorts. So looking at the open versus robotic partial nephrectomy comparison, and looking at only the studies that has a mean RENA score that was adjusted, well, the story is pretty different. Open partial nephrectomy has nothing. We were very surprised. No superiority of open partial nephrectomy versus robotic partial nephrectomy, but as you can see here, the equality of the outcomes of interest is even higher when you're comparing robotic versus open. And therefore, again, as you can see here, approach matter, but one of the things that we have to consider is that also the disease characteristics. Some of the questions, fortunately, will be answered with the new trial, open versus robotic, that is undergoing. One of the member of our YAO team, Karl Kowaleski, and the team that is working with, they are now undertaking this huge randomized clinical trial comparing open versus robotic partial nephrectomies, and I'm pretty sure that some answers will come from there. And what about the complex renal masses? So when you have a renal score more than 7, so when you have something that is really, really big. So as you can see here, again, the quality of robotic partial nephrectomy open was in terms of operating time, transfusion, intraoperative complication, major complication, and positive margins. Of course, those results has to be taken into consideration with caution, because again, everything that I'm showing here is biased by the retrospective nature of the papers that has been included in the meta-analysis. And again, those are the data that should, again, everything should be taken with caution. Let's compare laparoscopic versus robotic. And as you know, there are 51 publications comparing open laparoscopic versus robotic. The total number of patients was around 8,000. And when you're comparing laparoscopic versus robotic, considering the prospective and retrospective studies that has been included in this systematic review, the robotic partial nephrectomy was superior to the laparoscopic partial nephrectomy in terms of warm ischemia time, conversion to open, conversion to radical nephrectomy for intraoperative complication reasons, transfusions, intraoperative complications, positive margins of overall mortality. And equality between the two approaches was found in terms of operative time, estimated blood loss, post-operative complication, admission, and cancer-specific mortality. Again, those data should be taken into consideration with caution, because again, the majority of those trials are retrospective. Again, let's compare laparoscopic versus open using the same RENA score. And as you can see here, again, superiority of robotic partial nephrectomy was found in operative time, warm ischemia time, conversion to radical nephrectomy, and length of hospital stay, but no differences for RENA score more than 7 performed laparoscopic versus robotic in terms of the estimated loss, transfusion, post-operative complication, and post-surgical margins at recurrence. Transperitoneal versus retroperitoneal. Again, all of them were done robotically, but here we are comparing transperitoneal versus retroperitoneal. 5 studies were comparing for almost 1,000 patients reported. And as you can see here, we found an equality in terms of transfusions, conversion, intraoperative complication, postoperative complication, meaning that the robotic approach can be safely done transperitoneally and retroperitoneally. Healer control, different techniques. We know that there is an off-clamp versus on-clamp. 9 studies comparing, so I will go for sake of brevity. But no differences in terms of transfusion, conversion, and post-surgical margins, which means that is extremely important. One of the things that we found is that when the robotic partial nephrectomy was performed with an off-clamp approach, OR time and the decrease of percent of the GFR was superior in the off clamp versus the on clamp. Again, we talk about surgical approach. Let's talk about the tumor factors. So if the question can be, can the robotic approach be performed for complex renal masses? How they compare when you're comparing more than 4 centimeters versus less than 4 centimeters, endoscopic versus esophageal, hilar versus non-hilar renal masses, and anterior versus posterior tumors. Here you can see the comparison between the different renal scores. So according to renal scores, again, remember that the definition of complex renal masses can be defined according to the renal or to the Padua. 10 studies compare comparing almost 1,500 patients. And as you can see here, there is a comparison between the robotic approach that can be performed for complex renal masses versus non-complex renal masses. When you're comparing the robotic approach performed for more than 4 centimeters versus less than 4 centimeters, as you can see, there is a superiority, of course, of the outcomes of interest when the robotic partial nephrectomy is performed for renal masses less than 4 centimeters, but no differences in terms of intraoperative complication, positive surgical margins, and overall mortality rate, meaning that the robotic approach can be safely done. Also, might be, let's put it this way, might be safely done also for renal masses more than 4 centimeters. The there's might is related to the fact that the majority of the studies are retrospective. So again, those data should be taken into caution because of the nature of the studies included in this meta-analysis. And let's talk about patient factors. So can the robotic partial nephrectomy be done for a patient with less than 70 versus more than 70 years old? Can be done with abnormal BMI, with the CKD, or with prior abdominal surgery. So let's check. 2 papers compare less than 70, more than 70. So definitely we need more data on this. We saw that when the robotic partial nephrectomy was done in a patient older than 70 years old, we found basically no superiority and no inferiority of the in 70 versus less than 70, but equality in terms of operative time, estimatable loss, warm ischemia time conversion, transfusion, etc., which means that in selected patients, we might recommend also performing the partial nephrectomy, the robotic approach, also for patients older than 70. Again, here we're talking about just only 2 papers, and definitely if there is anybody in the audience that want to run any prospective trial, it should be done definitely, because this is an area that needs and requires definitely more data to answer the questions. Abnormal BMI, 7 studies, almost 3,000 patients. And as you can see here, there is a superiority, of course, of normal BMI versus normal BMI in terms of operative time, estimatable loss, and overall postoperative complications, but equality of conversion, transfusion, specific minor and major postoperative complication, intraoperative complication, positive surgical margins, and overall mortality rate. Again, this forest plot can show that the robotic approach might be safely done also for higher BMIs. Of course, in experienced sense and in selected patients. Again, we saw today that the host factors, such as tumor factors and patient factors and surgical factors, have an impact on robotic partial nephrectomy. And considering the available data from the entire contemporary English literature, robotic partial nephrectomy provide mostly superior at the minimum equivalent outcomes compared to the open across all the aspects. And some evidences, but not all, of course, for superiority of robotic partial nephrectomy over the laparoscopic partial nephrectomy is equally compelling. Off-clamp, selective, and super selective clamp and early on-clamp hilar control techniques are safe and feasible and can be done as an approach during the robotic partial nephrectomy with similar perioperative and oncological outcomes compared to the on-clamp robotic partial nephrectomy. And of course, minimizing the global renal ischemia may provide superior renal functional preservation. However, more data are needed and are necessary for a definitive conclusion in this regard, and we know that. Host factor impact on robotic partial nephrectomy, tumor size and complexity, as well as the baseline of the patient comorbidity correlated with perioperative outcomes after robotic partial nephrectomy. And patients with comorbidity, such as, for example, advanced age, abnormal BMI, CKD, or prior dominant surgery, should always be selected very carefully. So again, one of the biggest limitation of the entire thing that I just showed that we need to acknowledge is that it is almost impossible to evaluate the real impact of the surgeon expertise on the reported data. And this study did not consider the amount of parenchyma spared between the comparison group, which means that we know that the more you spare, the higher is the chance that your decrease of the GFR will be lower. And the overall suboptimal level of evidence, so there are no randomized clinical trials right now, and many are prospective or retrospective study with the heterogeneous group and the selection bias at the very beginning. And even though we try to do multiple sensitivity analyses to try to adjust for confound these variables, yet it is impossible to adjust for everything. And therefore, again, those results should be taken with caution. So again, robotic partial nephrectomy has now emerged as a safe, effective, and sometimes even preferred partial nephrectomy approach for the treatment of small renal masses. And given the adequate robotic expertise and a careful patient selection, robotic partial nephrectomy can deliver excellent outcomes, even for anatomically challenging tumors or abnormal patient characteristics. So again, if you want to find some more information about the studies that we included and the limitation of these systematic reviews, please feel free to check this publication, which now are in open access, so everybody can download them. And thank you again for this kind invitation.
So thank you very much, Dr. Cacciamani. I had the honor to listen to the early version by Inderbeer at the GU surgeons meeting for the first time. And at that time, I think that there was one question for me is, of course, how, as you know, this easy thing, shit in, shit out. So problem that you say, okay, if you do a vast analysis, how are you sure about the quality of the data that you put in your study? Can you maybe comment a little bit on this?
Yeah, definitely. So again, one of the there is always a saying, say garbage in, garbage out, right? So exactly. You know, and sometimes when you are performing a meta-analysis, you can amplify the limitation of the study that you are including in the meta-analysis. One of the things that we can do in order to minimize or at least to try to understand if there are some selection bias in the comparison groups is first run a biggest meta-analysis with all the data. The second thing is just selecting the propensity score or match comparison studies and to compare the findings with the main meta-analysis. And when it's possible, to do it's called backwards meta-analysis. So when basically you are meta-analyzing the baseline characteristics, and then you're going to select only the study that has a given patient characteristics that is not statistically significant different, and then you're going to plug them all in a different meta-analysis or sub-analysis. So we try to do that again. That's why we have 856 forest plots. And again, what we saw is that when adjusting by those confounders, of course, the enthusiasm regarding the robotic approach versus the laparoscopic approach was lower, which means that those laparoscopic and robotic approach are more similar than what we found. We saw, of course, some, still some differences when you're comparing open versus robotic. But again, I really believe that the majority of the answers that we have to our questions will come up with this new randomized trial that is comparing robotic versus open that is run right now in Germany. And I'm pretty sure that in 1 year from now, we should have some data on that.
I think that this is what I see the purpose. It's a lot of effort, just maybe to get out, as you pointed out, some of the open questions. For me, for example, and you know a little bit with Inderbeer Gill, there is not a clear correlation, even in the studies you have, between warm ischemia time and the loss of GFR. So sometimes they are equal, but the robotic group is better or something, even if the warm ischemia times are equal. So this is not completely.
Professor Rassweiler, you cut out a little bit. What you're saying?
Do you hear me? I know I had some comment here. Do you understand me now?
Yes, now I can hear you. Yeah.
Okay. So you know about the hypotension approach that Inderbiegel used. This might not be very good for renal function. It might be good to not for less ischemia, but of course it might interfere with the renal function. So I think there are some things that are not 100% clear, and it's not your fault because you are just trying to use a technology or let's say a systematic analysis to get out some of this data.
Yeah, correct. So, but again, there is also the data from the clock study that are showing that there are, not so many differences. And again, there are some, I would say that the fact that we wanted to go out from this retrospective world, in order to, and you can see that, so there is a huge enthusiasm in trying to perform some new randomized clinical trials. And that, of course, is, everybody all over the world that is trying to do that some randomized clinical trials should be, complemented for sure, because that is the real way that we can have for, going out from these impasse of the retrospective studies. This is what we have right now. So again, it can give us just a picture of the situation. Systematic reviews are just not only a way for summarizing the data, but also a way for showing the limitations and try to move out from those limitations to improve in the patient care.
Exactly. Thank you very much.